On the first day of treatment, we try and let the patient know that it's going to be the longest day of treatment for them. And it's not that the radiation is going to be on any longer, because it's not. It's more of all the checks and balances that we have to do as therapists that first day. So prior to their first day, it could be the day before or a couple days before, you are going to be going through your schedule and see when somebody's going to start treatment. And you're going to check their chart to make sure everything's good to go before that day, because you don't want to have a patient show up on a day and then realize that there's stuff missing. So what we'll do is we double check that we have a prescription and plan that are both finalized and signed, so they're approved by the radiation oncologist. Sometimes they get a little bit busy and they forget to actually sign it, so we want to make sure that that's all completed. We will go in and make sure the quality assurance testing has been completed and approved. That will be done by the physicist. So even the stuff that we do as therapists, the physicist will sign off saying that yes, we did complete our side of everything. We're going to check for our setup notes and images that we would have taken during simulation. That's going to be, do they use a vac lock or do they have a mask? Do they need a bite block? Do they have a diving ring to hold their hands across their chest? Are they using a block between their feet and a rubber band? Anything that we're looking for to help us set the patient up that day correctly. So then fast forward to the actual day of treatment. The patient's going to arrive and they'll usually check in with the receptionist and they'll go to the waiting room. Once we see that they are here checked in, we are going to be able to pull everything up in the machine so we can see their information on the screen with their treatment plan. We'll go into the linear accelerator vault and we will set up the table with their immobilization devices, get a fresh sheet on the table, get them anything else they might need for changing purposes, the whole 9 yards. Okay. Sometimes on that first day, they may want to meet with the radiation oncologist prior to their treatment to do kind of a baseline physical where they're going to get their weight on the first day. They'll get their blood pressure, pulse, oxygen, all that stuff, and just kind of get a baseline to see where they are. Sometimes the oncologist is fine doing this after the treatment. It just kind of depends on your physician. But once we go retrieve the patient from the waiting room, we're going to bring them back. And at our therapist consult, we are going to ask them the same 3 questions every single day. We're going to ask them their first and last name. We're going to ask their date of birth. And we're going to ask them what side of their body we are treating. So they can say, my name is Jane Smith. My birthday is 12/17 of 1982. And I am getting treatment on my right breast. That is going to help us verify the person that's standing in front of us and the plan that we have pulled up and everything else that we might be looking at. We don't want to accidentally treat the wrong patient or the wrong part of their body, because some patients will come back and they may even have a couple different sites that we're treating. We're going to give the patient a tour of our control area where we sit. We'll show them that we can see them with the audio-visual monitors and that we can be in the room in seconds if they need us. We will then go into the linear accelerator vault and we'll show them where the table is, how the gantry moves. We'll get them kind of familiar with that and then let them change if they need to. So just an overall view of what to expect before we actually say, all right, hop up onto the table. We try and get them a little bit more comfortable with the situation. So as I mentioned, we'll show them where all of us are going to be located at our control console. We're going to verify who they are from their first and last name, date of birth, and their site of treatment. Then we'll go into the linear accelerator vault and show them the table, gantry, show them what we're going to be laying them on with their immobilization devices and set them up the same as the simulation. And then up on our screen, we are going to be able to see more information about the patient so we can double check that, as well as we can go ahead and start looking into the future of when they might be available for their next treatment. So we can get an idea of that while the patient's getting set up. We will then allow the patient to change or undress as necessary, just like they had for their simulation. So if we pulled their pants down a little bit for their pelvic simulation, then we're going to do the same thing for their treatment every single day, and we'll just cover them up. So we'll begin the setup at the treatment table. We'll help them get on the table. It'll be lower towards the ground, so it's easier for them to get on. We'll get them situated within their immobilization device, get their arms situated how they need to be, and then we will raise them up. Almost always, there's going to be two therapists that are going to help with this process because they have marks on either side of their body, so that you can be aligning on one side and the other therapist can be on the other side, to constantly have visual of how things are changing once we're moving. So sometimes we have to roll the patient, meaning we have a sheet underneath them. So if my mark is not in the right spot and the other person's is also not, but one of them's high and one of them's low, we can roll the patient to try and get them into position where those crosshairs are aligned with the lasers. We also can kind of shift their hips back and forth on the table with that. The sheet on the table, we can move their arms if necessary. There's a lot of just fine tuning, tweaking that we do to help us get into position. So once we're good, our marks are aligned, and we raise a patient up a little bit more into the gantry closer there, we are going to follow the setup notes that are on our screen. So this is going to tell us if we are, first off, in the correct area. And then second off, it's going to show us if the dosimetrist has any additional shifts for us. The dosimetrist can plan from our original simulation images how far the tumor is from those original marks that we made. So we are just finding the absolute midpoint of mid-sagittal and mid-coronal plane. But if we have the tumor, it's more to the right side, the dosimetrist can tell us exactly how much to go to the right side and how much to raise the table to align to that component. If we use motion management, then we will turn this on at that point. With motion management, you do have to dim the lights in the room. So I always let my patient know that I'm turning the lights down. There's usually just a button on the table that you hit, and it kind of goes more of an ambient lighting, very, very low lighting. And then you'll shine the motion management on them. That's usually a bright red light because it uses infrared. Once you shine this on the patient, that screen from the OSMS or Align RT, whatever you use, it's going to show you whether you are within your range or not. So remember, we want everything to be green and make those slight adjustments. We then will inform the patient that once we're good to go, that we are going to exit the room, and for them to hold still throughout the treatment and to let us know if they need something, just holler out. And if they do, then we can be in there instantly. It's very, very important that they understand they have to remain still, because if they move, then we have to go back in and reposition them. Usually the first couple, they might have a little bit of jitters and struggle to lay still, but then usually after that, they're pretty good. So after I usually say, all right, here we go. Then we'll exit the room and we will shut the vault door, because remember that interlock has to work and it has to be shut for the radiation beam to turn on. So then here we have our patient on the table. We are getting everything set up. It looks like we're going to be doing some imaging. So the radiation therapist is getting the imaging arms in the location that's needed. So we have the MV out and we also have the KV out. Sometimes you need both of them. And then the patient's already aligned on the table, ready to go. This picture down here was what I wanted to just demonstrate is up on the screen for how we are going to move the patient. So when it says avert, that's how high or low the table is. Longitudinal is how far in or out it is compared to the gantry. And then lat is going to be left or right. So as you can see right now, all of that is orange. Orange and these little triangles means not good. We are not in the right spot. We need to get back into the right component. So this is saying that we are needing to go to negative 2.5. So you're going to have to shift this to the correct side by 2.5. And then you have the longitudinal. You're going to have to adjust that by 1 and then adjust the lat by 1. So once they get in, you get these numbers to match, which they move very slowly. So they can move by 0.1, 2, 3, 4. So very, very small increments it can move. And it's very sensitive. So like sometimes you barely touch it and it jumps up to like, oh, you moved 5. And I'm like, I didn't, I promise. But sometimes it's just very sensitive. So once these numbers are aligned, the orange is just going to go away. There won't be a color on it anymore. It'll just go away. And that's what we want. And so this demonstrates the vert, longe, and lat, if you were interested in how it moves. And then over on this right side is just the pendant that we have again. We can turn off the room lights. So this is usually to dim the lights, and then this is to turn the lights back on. We can adjust our collimator with our MLCs right here. That just means when you click on it, it will go to the shape of the first beam. And then down here are all the components for how to move the table left, right, up, down, in, out, all those things. We also can open up our imaging arms down here as well. Here is our motion management system. So we turn the lights down and then we shine a bright red light on them, and that's going to monitor their skin. And then it's going to tell us exactly how far we are from our threshold or within our range. So we want all of it to be green, which it is here. That's great. And if it goes outside of that, it hits the line or goes out, it's going to go red. So that shows us that they are out of tolerance and that we are going to, the beam's going to stop. It only allows the beam to continue when it is green. When we exit the room after we have started OSMS or this motion management, we are going to see our door that closes. Some doors are going to be more like elevator doors in the sense that they kind of close from either side, but some places, like the one that I was at, closes like a true door, but it was a big metal door. Still, it closed, it only opened and closed from one side. So that was a little bit more like a regular door. But most of these places these days have some type of press button. So it's kind of like a handicap button where you press that and it opens or closes. Another one looks like this. It just really depends on your facility and what they had installed, but it's usually just a button that you press and it starts to open just like a regular automatic door. Once we get back to the treatment console area, we are going to begin our pre-treatment process of imaging. So depending on the situation, we could be doing a CBCT, which we're missing a C there. It should be CBCT. I'll fix that on your PowerPoint. And we could also be doing kilovoltage or megavoltage images, just regular flat x-rays. It really just depends on the patient's type of cancer and what type of treatment we are preparing to do. We will then match our CT images from simulation, or if you remember me talking about the digitally reconstructed radiograph or DRR, that is created by the treatment planning software. That if we have a CT from simulation, but we are planning to just take an x-ray for our imaging every day, then we need an x-ray to compare it to. So it will take the CT and reconstruct a x-ray out of that so we can match it every day. Once we have confirmed that everything's lined up the way that we want it to, usually the radiation oncologist has to approve it on the first day, like actually has to type in a password to approve it. We will then shift the table by any tiny little millimeters to make sure that it is aligned the way that our images are. Typically, our physicist, therapist, and also the radiation oncologist will be present. So there's quite a few people at your console for those first days of treatment. Everybody just has to agree on everything. We'll do one last timeout. This is going to be where one person's going to read the treatment plan from their chart online with every beam. So if we have 5 different beams, we're going to read every beam, what the monitor unit's going to be, what is the start location, what is the stop location, what is the angle, what is the MV, all of this stuff. So we're double checking that absolutely everything is perfect before we beam on. So while one person's reading, the second person's checking on the actual treatment machine. So the linear accelerator, the console that we have at our table, we're double checking it on there. So once everything's proven, we are then approved to beam on. Typically, because that process takes a little bit more time on the first day, I'll usually hit my little microphone button and say, all right, we're ready to actually give your treatment now. Make sure to hold still. Just so they know that, hey, that part's over, but we're not completely done yet. So then we'll beam on for each beam of the treatment, and we'll just keep watching the patient through those audio-visual monitors to make sure that they don't move or need anything during that time frame. And that treatment's only going to be just a handful of minutes. They're usually on the table longer for positioning and all these things rather than the actual treatment. The actual treatment's very short. So here's how we're doing our imaging. The patient will lay on the table, which is obviously labeled by D. And then E1 and E2 are our KV arms that we are able to take just regular KV x-rays, or we can also take our cone beam CT with that. And then B is our gantry head, and C is going to be the MV imaging arm. So that would be an x-ray taken, but with an MV. And we also call that our portal imager. So then up here, this little F, that is usually our optical management system. So that's going to be the thing that shines the red light down on the patient and is able to catch as they're breathing. Over here, we just have a KV situation going on with our X-ray tube imaging underneath the patient. And so here, it looks like they could be doing something like with their esophagus. Here are a few more opportunities to look at how we match our patients. So up here at the top, we have a patient for prostates. And so I'm going to kind of come down to the bottom portion here. So we have a whole x-ray here. Okay. And then we have a smaller x-ray inside of it. Okay. So typically with the prostates, the smaller portion is going to be what is our digitally reconstructed radiograph. Okay. And then the outer, the larger picture is going to usually be from the KV or the MV imaging. All right. So you can see that up here. So over here, we have the actual KV image, which is the big one. And then we have it flipped over the top here, kind of in the center and onto the left. So you can just see as they're laying on top of each other. So our job is to match the structures that's within that digitally reconstructed radiograph and then the x-ray we just took today. So if I'm looking at my KV image all the way to the right here, let's say my pelvis from my digitally reconstructive radiograph was all the way up here. I am going to have to figure out why I'm so far off. And what we're going to do is we are just going to shift the images until they match over the top of the true pelvis there. And once it's moved, it's going to tell me how much I need to move the table. If it's a large shift in the table movement, typically we're just going to see what it is and we'll just go in and move the patient and then re-image them, because we really don't want to move the table more than a couple centimeters just based on the imaging. Okay, because that information, the shift is stored into the computer and it shows us that we didn't align correctly. So we will re-image after we have repositioned, and then we should be right there where we need to be. So over here on the right hand side of the page, we have our patient that's going to be more of like a mediastinum, posterior, it could be spine, or rib, honestly, when I'm looking at this a little bit more. So when we have an APKV image, the lat, I just wanted to show you what an MV image would look like comparatively. So it doesn't have as good of skeletal anatomy. It's very black and white, doesn't show as much contrast for the lower portion, and it makes it more challenging to match. So if we're only looking at soft tissue, we can usually get away with MV and just like the outline of a structure. But if we're really looking for a detailed analysis of where I need to align, we're definitely going to do KV. And then we have our cone beam CT down here. So with this, it's kind of backwards from the DRR. So our little circle here is what we just took today as our cone beam CT. And then the whole outline of the chest, the whole thorax, that was from the original CT simulation. So as we're looking at this, we're just going to try and match the ghost image on top from today to the old one and get all the structures matched up before we actually beam on for the patient, because we got to make sure we're in the right spot. Here's another really good example of us aligning for a patient. So this was a cone beam CT. I'm looking at my axial sections up here on top, and then these are my coronals down here. And I have a sagittal over here. So looking at the very first top left picture, I can see I have two CTs on top of each other, and they are not aligned. So my job is to try and move the objects so that they are aligned. So right now I'm seeing that we have this kind of corner right here, and then we have this here. So what I'm going to have to do is I'm going to have to take this new line and I'm going to have to push it that direction. Okay. As far as like anterior to posterior, we're pretty good there. But left to right, we need to shift the kind of the new ghost image to the right. And so once we have done that, this is what it looks like now overlapped. Then down here in the coronal, you can also see that that was the correct move because you can see here where that line is and then where the line is of the lung right here. So I need to move everything to the right, just like I did on the last one. Okay, and as far as up and down, again, we're pretty good on that, as far as I can tell in that picture. But as you start moving it back and forth, you'll see if you need to move it up or down, left or right. You just use your arrow keys on your keyboard, so very easy to use. And then the last image, the sagittal, you can just see kind of front to back if you need to alter that as well. Down here, we can also see that we may need to look at what shift we are doing. So the shift is going to show up right here. It'll tell me lat, longe, and vert based on what I just moved my picture around to look like. It'll tell me how much I changed. So I can then go in and move the patient if it's too much, or I can just go ahead and hit apply shift. And once you hit apply shift, the table knows what to do. So you're going to hold a button and it's going to allow the table to shift into place where you move the picture. So it's very smart. Great option for our patients because we don't have to do as much fine tuning manually within the room. So that saves on some of the human error as well. Here's some of the matching, what we could do for a brain. So with the patient on top, we have a DRR, we have what we just took that day, and then as we lay them over the top, you can see that there's kind of a haziness because they're not 100% aligned. So again, we're just going to kind of move side to side, up and down to try and get it as perfect as we can to get rid of that kind of haziness or doubled exposure looking picture. So that would be for a whole brain that we were treating there. And then a little bit lower, we have an image of a brain where we are probably going to treat only one location, looking like it's going to be kind of like behind the eye. And so when we are treating here, we are identifying again the outside structure of where we need to be as well as within the tumor. So what they have done here is instead of just using two pictures, they've done the two pictures, but they've kind of split it up into quadrants. So you can see the original, the one that we had, and then you can see the one that we just took. So they just have it in quadrants there, but they have it in this kind of like side profile from the front. And then we have a true like CT image. So we have, again, a sagittal CT, we're going to have a coronal, and then our axials down here. So they had quite a bit of imaging with that patient to be able to look at it and identify, are we in the correct location or not? With our CBCT up at the top for a patient for prostate, we are able to identify looking at the femurs. If we're in a good spot, you can look at the pubic symphysis. And then once we get a little bit higher and we get into the bladder, prostate, rectum, we can look for those contours and make sure that we're aligned. Also with that CBCT, what we're looking at down in the bottom picture is we have our cone beam. So that's this kind of section here. Okay. And then the background was our original CT. And so as we're aligning, we're going to make sure that things like our sacrum coccyx are aligned, our pubic symphysis up in the front. We're going to make sure that the OAR and where our prostate is, if they have the spacer, if they have fiducial markers, we're going to make sure all of that is in the correct location. And so here's another picture of that CBCT of the breast, how we had kind of the overlapping of the circle, which is the new one, versus the whole CT was the old simulation one, and then how we were able to align it to be as close as possible for our alignment. Down here is our audio visual cameras, and so we are able to move it a little bit, kind of side to side, up and down. We can also turn up the volume and turn it down if needed. We usually have two, if not three monitors. And then over here is our true console where we're able to control our imaging arms. We can control the x-rays that we take, the CBCT. We can actually shift the table from here. we can, just based on the shifts we made from the picture, not like every which way. And then we are able to actually do our beam on. We do have an emergency stop button up here. And then if they start moving and we don't need to like completely stop the whole treatment, but we need the beam to stop, we can just hit beam off. So just kind of like a pause, and then we're able to turn it back on if needed. Once the treatment is finished with everything, I will still usually come over the intercom, or as soon as I open the vault door, I'll say, all right, hold still for just a few more minutes. We're almost done. And at that point, we are going to make new marks on the patient's skin where we finished our treatment, because that shows us where the tumor was, and that's going to be the best ISO center location. The ISO center is exactly the point inside the patient where that tumor is. We will then obtain our source to skin distances. So looking from the gantry to the patient's skin, we'll usually get one kind of up top, from top of the patient, and then from left and right. And we'll write all that down. And then lastly, we'll take some photos to put into the patient's setup chart. So we will ensure that the patient knows these are not just for their fun or anything. These are just for your chart. They're not going anywhere else. They don't have, nobody else has access to these. That way they're a little bit more comfortable, because a lot of them are going to be fairly unclothed during this process. Once we're completely finished, then we will allow our patient to get down off the table. So we'll lower everything back down, help them off, and we'll allow them to get changed back into their clothes. And then at that point, once they're finished, we can answer any questions that they might have for future reference. If they need to talk to the doctor or they have questions for them, we can get them in contact with the physician. We can ensure that we get their daily treatment scheduled. So if we didn't do that already, we can go back to the console and get on the computer and look at the calendar and see what would work best for them. I know at my location, we would also send the patient home with an actual printed out calendar of all of their treatments. And then after that, we would escort them back out. If they had family with them in the waiting room, we'd go back to the waiting room and grab them before they leave. That way they don't accidentally leave without their family members. And then after that, we're going to finish charting on our own. Sometimes we will be able to do it right then and there. Other times that may have to be put off just a little bit until we have more of a break. Just kind of depends on if we're running behind or not, but we'll go ahead and set up for the next patient then. So just a few more pictures here. This is just showing you our optical distance indicator. So that's going to tell us our SSD from the gantry to the patient's skin. This one was just taken a little bit better on top of the QA Phantom. But if you want to see it on an actual patient, that would be laid down here. So it kind of just takes over the laser light where that would be located, and it just tells you to that point how far is it from the gantry. We'll also make marks for our patient. So up here in the corner, you can see that this patient has several marks, right? So they have a red mark here and a red mark here. Those are likely the very first ones we made from simulation and we keep, because it's marking mid-sagittal plane and mid-coronal plane. That's just a good starting point for us. And then our dosimetrist can say, hey, actually, our treatment's going to be right here's where we need to center. So at that point, when we go to shift the patient, when we're just getting set up, I can just slide my table over and align to where they said that tumor is actually located within the breast. Okay. These were some other marks in case they had something else that needed treated, like if they were lymph nodes or anything like that that needed to be aware of. But usually you just have your few marks, both sides and the top, and then you may have an additional one for where that tumor is located. So within our schedule, we're going to be able to see the patient's whole schedule, as well as this is in ARIA, which is a good radiation oncology platform. But in ARIA, we can see our whole day's treatment plan. So we can say, okay, these people are being treated at 8, 9, and 10, and this person's at this time, and this person's at this time. The different colors will mean the different types of treatments or specific instructions that you might need to do. It'll also say whether the doctor needs to see them. It has all that information for great communication between the whole team, so everybody knows what's going on. And then over here, you will actually like select on the patient's chart. They show up to show you that, yes, these are all the people that are being treated today. Would you like to open their chart? And they usually have a picture of the patient, all of their information, everything that we've put in from the very beginning. So our system's a little bit different than what some hospitals use. because everybody needs to know what's going on for everything. It's not like in radiology where you only need access to a few things within their chart. We need access to pretty much everything to know, hey, do I need to make any modifications today? Do they need to see the doctor first or after? Do they need to see the social worker, dietitian? Are they not coming today? Did they call out sick? Are they going to have to come in later today? What type of treatment are we giving? Do we need to do something special for them? All of those things. So there's a lot of communication in radiation oncology, and it's very important that everybody is aware of that and is willing to be a team player.